Good morning, everybody. I'm Mark Travin. I'm coming to you. I'm from Pleasantville, New York, Upper Westchester, and I'm from Montefiore Medical Center, Albert Einstein College of Medicine. Of course, you see this was supposed to be in Las Vegas. So too bad we're not there, but I hope you're all safe wherever you are. This talk it's a SPECT session, of course, and we're going to talk about the basics of myocardial perfusion imaging, which is the main thing that's done for nuclear cardiology. And with it, we'll also talk about functional imaging with gated SPECT and with viability using SPECT tracers, although if I have time, I will talk a little bit about the PET tracers for this. Okay, so why do we do nuclear cardiology in the first place? Well, that's because cardiovascular disease at this point is still the #1 cause of death in the US, although that could potentially change this year. As you can see, the prevalence of cardiovascular disease in general is about 121.5 million. And this is 2016 data. In 2016, 161,000 Americans died of cardiovascular disease, 19% less than 65 years of age, and 36.5% of deaths attributed to cardiovascular disease were less than age 75, which is below the life expectancy in the US of 78.6. So, of course, if people live long enough, they're going to die of something, and one of those could be cardiovascular disease. But we're more interested in trying to find patients who are at risk of dying of premature cardiovascular disease and intervening in ways where we could prevent adverse events. I've used this slide for years, and I've always talked about cardiovascular disease has been the #1 killer since 1919, and most people didn't know what I was talking about then, but I guess they will now. As I just added this, COVID-19 may surpass this. There's already about 50,000 deaths in the US, or almost a third of the way to the cardiovascular disease. But until now, of course, the cardiovascular disease was the highest one. It claimed as many lives as the next two leading causes, cancer and lower respiratory diseases, and the estimated cost is very high. You could see here, for a while, the death rates were this here. But then in the 80s, the rates of men began to taper. Women tend to lag behind, but by about 2010, it actually came down substantially. Although there's been somewhat of a little increase lately, maybe because of obesity, diabetes. But you could see over the last maybe 20 or so years, we've significantly decreased the incidence of cardiovascular disease deaths. And why might that be? Well, two things, probably changes in risk factor management, like statins and beta blockers and aspirin, and some lifestyle changes, less people smoking. And then also, once people have cardiovascular disease, we have better therapies for it, so they're living longer with the disease. The question we want to pose for us now, to what extent does imaging help in reducing the cardiovascular disease deaths? Is our imaging having any good in identifying people sooner, in prompting a more aggressive risk factor reduction and preventive factors? And two, does the imaging somehow help and manage the patients that have disease to lower the event incidence? And that's a very complicated question to try to answer, because in part, it depends how people react to what the images show. And if you have images that show that patients are higher risk, but nobody acts for that, there's no risk factor reduction and no change in management, then of course it's hard to show that imaging has any effect, even though it would if if the referring providers or patients follow.
Good morning, everyone. The second talk of the SPECT Neuro series is SPECT Imaging of Neurodegenerative Diseases. Let's start. So I will begin my talk with some relevant introduction for neurodegenerative disorders. Then I will talk about role of SPECT imaging in neurodegenerative disorders. We'll talk a little bit about its role in dementia. The most of the talk will be on dopamine transporter imaging. And then in the end, I will discuss role of SPECT imaging with the help of cardiac MIBG scintigraphy in patients with movement disorders. Let's talk a few slides on the relevant introduction for neurodegenerative disorders. So neurodegenerative diseases or disorders is an umbrella term with many group of disorders. However, they have one common theme, which is abnormal deposition of intracellular and or extracellular protein in the brain, which eventually results in progressive neuronal degeneration, neuronal loss, and brain cell death. So broadly, neurodegenerative disorders can be divided for this talk into dementia, which includes most common Alzheimer's dementia, dementia with Lewy bodies, and frontotemporal lobe dementia. And the second group is movement disorder, which the most common movement disorder is Parkinson's disease. So let's now talk about the role of SPECT perfusion imaging in dementia. So their repetition from previous talk, the basic principle behind brain SPECT imaging is that whenever there's a increased brain activity, this leads to increased regional blood flow and increased regional glucose metabolism and vice versa. That means if there's a regional decreased function in the brain or some abnormality in the brain, which results in decreased blood flow, there will be a corresponding decreased glucose metabolism. And these flow and glucose metabolism are directly linked. Flow can be measured with SPECT tracers. Glucose metabolism can be measured with FDG. So this is the example of a subject whose visual cortex was stimulated with a checkered circular diagram, which results in activation, which will result in increased blood flow to the visual cortex, occipital lobes, and eventually will also result in increased glucose utilization in the occipital lobes because of neurovascular coupling, and this flow and glucose are directly linked. Again, another repetition because it's important to review how a normal SPECT perfusion looks like. This is a grayscale and rainbow scale, which we commonly use at our institution, and a corresponding axial slice at the level of basal ganglia. So few important points to remember. There's a concept of differential perfusion, which means that there's a differential perfusion between the gray and white matter. Our gray matter has about 3 to 4 times higher perfusion compared to the white matter. That's why we see a rim of activity in the cortex and lack or decreased activity in the underlying white matter, and increased activity in the basal ganglia and thalami because they are gray matter structures. So we will see increased activity. So area with the highest activity in the brain is usually basal ganglia and thalami because they are very metabolically active, highly perfused, and occipital cortex. The area with the least perfusion in the brain is usually anterior and medial temporal lobes, including hippocampus. And on perfusion imaging, the cerebral cortex and cerebellar hemisphere perfusions are pretty much equal.
We're going to move on now and wrap things up with some unknown cases. So I'm going to go through a huge number of slides in a relatively short time. So here are some cases. What I'm going to do is I'm going to put the case up, take a look at it, in your mind, make a quick determination about the answer. I don't want to linger on them, and then we'll go back and I'll go through the questions. So here's the first case. So first off, the question is, what's wrong with this case? So I will tell you this is an attempt to do a bone scan, and it doesn't look good, right? So what's the problem with it? That's a cobalt marker, injection in the arm, huge bladder, but there's something else. And the patient went to the bathroom, contaminated himself, unfortunately, and then we repeated the study right thereafter. So this is 20 minutes later. That's just exenteration, ignore that. What went wrong on that image that went right on this image? And the answer is, this would be the first case of the day, and the answer is off-peak. Now, honestly, this is a historical reference because modern cameras, you punch in bone scan and it sets it to 140 keV. So this is more of like a classic exam type question. But if you leave the scanner on the photo peak that's used for cobalt for the morning quality control, which is 122 keV as we heard, then you end up imaging this bone scan at 122 keV, which is entirely Compton downscatter from the 140, and as a result, although it bears a resemblance to the normal distribution, everything is fuzzy and mislocated, and it's kind of like a ghost-like image. So that's an off-peak image, and it's a classic appearance. How about the next one, sticking with quality control? So first off, what do we call this kind of an acquisition? This is the morning uniformity flood field, they might say, and what's wrong with it? So we have a couple things wrong with it. And what's wrong with it is basically these are all defects of the field. And here's basically the summary of what they are. There's a non-functioning photomultiplier tube, which again is huge, much bigger than the tube. There's a non-uniformity there, and there's a crystal defect where it got slammed with something. So when you see something like this, you don't do anything, you call service. Here's another example of malfunctioning electronics. So that you see the photomultiplier tubes, and then it's fixed. And again, these are all electronic issues with the non-uniformity. So you don't image with this. You got to get it fixed. Okay, how about this one? Here's a real patient. So first question is, and when you're looking at a nuclear case, the first question often is, what's the study, right? So we got to kind of figure that out. So what is the examination here? And if you're not immediately clear, then I would point out they were doing multiple repetitive images over some period of time not labeled here of the same body part. And so this is a HIDA study. Okay, so what do you think we're looking at? And that's kidney and bladder, which often means there's hepatic insufficiency. All right, there's an hour, here's 3 hours, and here's 24 hours. All right, so there's only one indication that would cause us to waste our time doing a 24-hour image. And notice the field of view here. This is a babygram. So we got no excretion, and what is it?